This is NICU Babies Parent Support with Catherine Whitaker, a podcast from Hand to Hold, a national nonprofit that provides free personalized support, resources, and community before, during, and after a NICU stay. My conversations here will focus on education and personal stories with medical and hospital professionals, counselors, therapists, and NICU moms and dads from across the country. Whether you're preparing for a NICU stay, you're currently there, or you're months and years past your stay, you belong here. The NICU is hard. We're here to help. I'm your host, Catherine Whitaker, the mom of 6 children, including my very own NICU baby, and I'm so honored you're here. Hey, y'all. Welcome back to the podcast. It's May. How did it get to be May? Here we are. And normally I interview different people, different topics every week. But for May, it's Pre-eclampsia Awareness Month. I felt like it was owed multiple guests from multiple perspectives. So that's what we're going to do. So for the next 4 weeks, we're going to dive deep into preeclampsia. First, I'm going to visit with maternal fetal medicine doctor. That's who we're going to visit with today. And then you're going to hear from 2 sets of parents with different outcomes with preeclampsia, as well as a somatic trauma therapist. I wanted to talk to them all. I think that it's a big topic. It affects a lot of women and a lot of babies. And I felt like it was owed more than just one episode. So today we're going to start with the big stuff. We're going to start with, what is preeclampsia? How do you know that you have preeclampsia? What does it even mean? And the perfect person to talk to that about is a maternal fetal medicine doctor. So Dr. Barry, I know you're going to love him. There is something uniquely amazing about maternal fetal medicine doctors. They deliver hard news to patients every day, to multiple times a day, but they have such an intimate relationship with their patients, much like an OB-GYN. So I can't think of a better person to kick it off than Dr. Barry. He is a specialist in maternal fetal medicine, a branch of obstetrics that manages and treats complicated and high-risk pregnancies. He's a native Texan, and he moved to Austin in 1978. He graduated from the University of Texas, followed by his medical training in Galveston, Fort Worth, and in Houston. He was the founder of Austin Perinatal Associates in 1997, and he served the women of Central Texas with complex pregnancies since that time. He is an expert in preeclampsia, critical care obstetrics, cancer in pregnancy, and cervical cerclage, and he is currently employed under Texas Children's Hospital as they expand their footprint in Central Texas. So without further ado, let's chat. Well, I'm thrilled to have Dr. David Barry here. He is the preeclampsia expert, at least much more of an expert than I am. His list of accolades is extensive and long, as y'all just heard in his bio, but I really wanted Dr. Barry to start. We have this 4-part series on preeclampsia. I know it is something that a lot of women who end up in the NICU with their babies have experienced. That's typically sometimes what lands them there. And it's such a big overarching issue that I wanted to visit with you to see what light you can shed, certainly maybe allay some fears of some women, but also give them some things that they should be looking for. So maybe we should just start with what is preeclampsia and how do you diagnose preeclampsia? I know that's a big question, but I thought we might start there.
Well, hey, Catherine, thank you for having me.
Sure.
Yes, preeclampsia is an interesting disease. It's a syndrome, and they call it a syndrome whenever you have a collection of symptoms all together. It's called a syndrome, though. So the preeclampsia syndrome used to be called toxemia or toxemia of pregnancy because patients look like they were poisoned, almost look like they were toxic. I don't know if you're a Downton Abbey fan.
I am.
To give away anything, not to give away anything, but Sybil, one of the daughters, had bad preeclampsia in the early 1900s, and that was kind of a good introduction to how we dealt with severe preeclampsia, as we didn't have any tools. And that was problematic. Now we have a handful of tools, but generally it's considered a syndrome unique to usually the 3rd trimester of pregnancy, usually between 28 weeks and delivery. Occasionally it'll come up a week or 2 even after delivery, but it's usually a syndrome of high blood pressure, unexplained swelling, particularly in your hands and your face, and unusual or high amounts of protein that's been spilt in your urine. And that's why the obstetricians will check your urine sample, check your blood pressure pretty much every visit once you get into the 3rd trimester of pregnancy. But there can be lots of organs involved in the hypertensive disorders of pregnancy, which preeclampsia is one of them. And they go all the way from mild gestational hypertension that we just need to wait and watch and pay attention to very severe syndromes like there's called HELP syndrome. It's HELLP syndrome. It's a form of severe hypertension. There are other um, similar critically causes patients to have critical illness in the third trimester. There's a hemolytic uremic syndrome. There are all kinds of really devastating things that can happen in the third trimester. Not to scare anybody, but but these are
No, it's
are
good.
out
It's
there.
good.
Yeah, these are out there, but yeah, many of them involve problems with the small blood vessels and the capillary networks of many organ systems of your body. So yeah, it's a very complex disease, but it's extraordinarily common, the mild versions of it at least.
Well, I'm glad that you brought up Downton Abbey because I'm a big fan, and I think that Lady Sybil certainly got people talking about preeclampsia that maybe did women a favor and giving them an idea of maybe what some of those symptoms might be. I mean, maybe give us an idea, Dr. Berry, how many women, I guess, nationally are diagnosed with preeclampsia, and then about how many of those, like how many of the women that you see in your practice, like what's the percentage?
So generally speaking, so there are about 4 million, 4.2 million babies being born every year just in the United States. And overall, the statistics say about 5% of them have preeclampsia or some of these hypertensive disorders, which equates to 200,000, more than 200,000 women every year just in the United States will have that. My version and the things that I see, I suppose my diagnoses are different. We see up to 10 to 15% of first-time moms
Okay.
will have some form of preeclampsia, and generally about 5% of the general population, even second, third, fourth time moms, that you can still get it. You're just 3 times more likely to get it with your first pregnancy, but it's up to 10 to 15% of the population.
So why more likely the first pregnancy and not subsequent pregnancies?
Again, preeclampsia it's so fascinating because if you imagine what's going on with a pregnancy, you're being transplanted with an organ, being the fetus and the placenta, uh, which is half familiar to you with all of your DNA and
Right.
proteins and that sort of thing, and half foreign, nothing personal to the dad, but he's a foreigner to your immune system.
Right.
So for some reason, we can transplant women with fetuses and embryos and placentas and such that are 50% foreign. If we try to do that with a kidney, say we gave you a kidney transplant, and it was only a three out. They talk about perfect matches and 3 out of 6 type matches and 4 out of 6, 5 out of 6. Those are what are called haplotype matching. And so yeah, if you had someone that was, your twin brother that you were having a baby with, you probably wouldn't get preeclampsia, but you'd have other stuff. It would be a mess. But no, we think it's your body's immune system's response to the foreign DNA and proteins and antigens that are come from the dad's side. And so you can imagine why, number one, why is that it happens that way? Why do you more likely, why is the better question is why do normal women without preeclampsia not get preeclampsia?
Right.
Uh, because there's some sort of immune tolerance mechanism of pregnancy that we haven't figured out just yet, that allows women to have a half foreign kind of invader into their body, and tolerate them for a full
Right.
9 months in delivery. So we think that because the mom's being exposed to the paternal antigens for the first time with the first pregnancy, that they're becoming tolerant of them. It's kind of like getting your I don't know, cedar fever shots, your allergy drops or your allergy shots.
Yeah.
Your first pregnancy is like an allergy shot for a future pregnancy for the same dad. But the reason I say that is, and it goes down by 60% with a second pregnancy, unless it's a new dad. If you get divorced, something happens, you have a new father of the baby. It's new FOB is what we call a father of baby. Um, you'll go back up and revert back to that 15% again.
Fascinating. The human body is fascinating. I know we could talk much more about that.
Well,
I'm a mom of 6, so I'm thinking like as my odds, and my preemie was my 5th baby. So you just never
oh
know
goodness.
what you're
But
going to
yeah,
get.
so don't get remarried. Is the clue. Hang on to your husband is the clue.
He's a keeper, so I'm sure he'll appreciate you saying that.
Well,
I
and
love
and
that.
to to take it one step further, what happens when you have a donor egg? If you have a
Right.
donor egg, in vitro fertilization from a donor egg, now the embryo and the fetus, the placenta, are 100% foreign to your body. So you have
Right.
a much higher, 2 to 3 times higher than the background population if you have a donor egg IVF baby for the first time.
Right.
So these are things that your infertility doctor may not tell you that when you decide to go down that
Right.
pathway, because it's so far down the pathway that it's not
Right.
in his wheelhouse to talk about.
No, I mean, I think these are all good questions that I think as a new mom, I was one who read all the books and studied all the things,
Yeah.
and then with subsequent babies, I'm sure that y'all as doctors appreciate that. Now we have Google. Google didn't exist when I had my first baby 22 years ago, but I do think that education and certainly the access to it has allowed women to learn more about things that they can do prior to pregnancy, during pregnancy, and certainly after pregnancy. I wanted to switch gears a little bit, Dr. Berry, because I think so. April is Black Maternal Awareness Month, and I know that there are lots of women of color who, at least the statistics say that they're affected at a greater rate, particularly women who are Black. Why? I guess the higher rate of occurrence of preeclampsia in women of color as opposed to women not.
And we really haven't figured out why that is. Women of color seem to get it, particularly in large Black populations. You see horrific preeclampsia down in New Orleans, for instance. They
Mm.
have, I mean, probably half of the admissions to the hospital before full term are related to preeclampsia. Same is true down in Houston. When I did my fellowship down in Houston at Ben Taub at Baylor College of Medicine, and we had a tremendous amount. In the type of preeclampsia that Black women have many times will be more severe. It's I believe the statistics from preeclampsia.org put a 60% increased risk preeclampsia just from being a non-Latino, non-white patient having babies. I don't know why that is. There's a higher proportion of women, Black women, that have across the board have prematurity. So preterm labor, preterm delivery, growth restriction, and preeclampsia are all higher in the Black population. And it's not necessarily a lack of treatment that we're seeing. It just seems to be either a genetic predisposition or something that's going on that doesn't seem to change based on even you can change socioeconomic status is highly associated with preeclampsia, preterm birth, but it seems to even when you change that socioeconomic status, it does not seem to change the occurrence of preeclampsia.
Well, I mean, I think that, in fact, one of my guests is a mom of color who had preeclampsia, and I have no doubt the story that she's going to share is going to be powerful for women who are in her certainly in her situation. But I think it begs the question that we have a lot of questions to ask our doctors. That
Oh yeah,
when you have a baby, it gives you the opportunity to sort of step outside yourself now that you're caring for someone else. And I think the
right.
mama bear instinct comes out, and you try to protect not only your own body but also the body of your baby. So now that we're in this, I don't know if it's post COVID, it's less COVID. I know that there was a study in the New Yorker magazine that came out in 2022 saying that I guess the rates of preeclampsia, as we sort of looked at what was happening during COVID and now post COVID, that the rates of preeclampsia went up. And I'm curious what your take is on that. If you think that that has more to do with the fact that more people were reporting, more people were testing for preeclampsia, or if that really did, if the reality is that there really is more cases of preeclampsia for doctors to treat.
And we did see pretty significant increase in preeclampsia just for a short period of time. There was probably about a 6 to 8 month period of time that we had seen an increase. Unfortunately, I don't have the statistics that bear that out, but you can imagine if preeclampsia is this toxemia sort of reaction that causes decreased blood flow to your organ systems. It can be decreased blood flow to your brain, to your liver, to your kidneys. It's in kind of pseudo medical terms, the best description I've heard for preeclampsia is intermittent regional vasospasm, and it's all about inflammation within the interior lining of the capillary networks. So what COVID does, it does the same thing. It causes inflammation of the lining, what's called the endothelial lining, kind of the inner lining of the tubes of the capillaries and your small blood vessels all over your body. And there's some suggestion that the vaccines do the same thing. That spike protein is a dirty thing, dirty animal. And when you have that spike protein from COVID infection, and even there's some theories about from the vaccination that sometimes that will increase it. There's a New England Journal of Medicine study that suggested that the vaccinated moms were protected a bit from it, but we know that spike protein from COVID specifically does cause increased microscopic blood clotting, damage to that endothelial lining, and increased uh, organ inflammation. So if you got COVID and preeclampsia at the same time, that would be a bad combination. And I think that's what was happening.
Well, I mean, I'm certain that there was an added amount of stress, which I don't know how much. I guess I think there might be some women listening that may wonder, like, did I cause preeclampsia? Could I have prevented it? Was I too stressed out about this thing? Did I cause undue stress for both me and the baby? I think that might be a question that a lot of women may ask themselves. There's this a little bit of a guilt factor. I think sometimes when you get yourself and find yourself in the NICU, what could I have done to prevent this particular situation?
Well, and this is one thing that I see with 100% of my patients. I've been practicing now in Austin for 25 years. I opened the practice in 1997, and 100% of my patients that have a complication, whether it's due to high blood pressure or diabetes or miscarriage or small babies or low fluid or something that's the instant mommy guilt starts immediately. That's the voice in your head as you did something wrong. And so I tell my patients, this is a new thing I came up with about 3 or 4 weeks ago. I say, okay, see that little box of Kleenex over on the counter? Yes. Okay, well, that's guilt, shame, guilt, and condemnation. You can get that, but you can only get that if you have done the proper things. If you've intentionally done something to intentionally hurt someone, then you get that box of guilt. If you did not do that, you do not have, it doesn't justify that you can collect that box of guilt. And unfortunately, all of my moms have the same complication and it's because you're a good person, you want to care for your baby, and you think that you're doing something, and which is a good thing to inquire about, but the actual reality is maybe one patient out of 200,000 visits, maybe two patients out of 200,000 visits in 25 years actually did something that harmed their baby. And those are really horrific stories, so I won't share those with you.
Thank you.
But the guilt is not warranted. If we could do something to undo that guilt, that the preeclampsia is not a preventable disease. If you are at super high risk, there are some things you can do that might manage it, but certainly things like stress or work or I don't know, yelling at your husband or, spanking your dog or whatever is going on in your life,
Right.
we instantly want to link that. There's a cause and effect. We want to link that. And there's just not a cause and effect by anything that people do to cause. I mean, if I could say, hey, Catherine, right now, can you start an intense inflammatory reaction in your liver and in your blood vessels?
Right.
Go. You got 10 minutes. What are you gonna and it's like what can you and that's the reverse of what's going on. But if you can't do anything intentionally to cause it, like right now, can I decrease the blood flow to my kidneys right now without using a surgical instrument to clamp off the
Right.
artery supply to my kidneys? There's just no way to do that. So the guilt is unwarranted. So if I tell all my patients you can't have guilt unless you've earned it. So it is not your fault. And I tell patients that every single day.
This is why you're a super doctor, and this is why when women are in, this is why when women are in a really stressful, anxiety-filled, pregnancy, of which I think many women listening to
Pretty
this,
much all
and
of them,
dads,
yes.
yeah, and dads too, who support those women, and
Right.
partners that it helps to hear that you did all the things right. And so I think when you get a preeclampsia diagnosis, Dr. Berry, what are some things that you can do to either um, prevent it from getting worse, or I guess causing keep it from escalating? Are there certain things that you can do as a patient? I know that there are things that you do as doctors, but
Right.
if someone's listening to this thinking, hey, I just got diagnosed with preeclampsia, is there something that I can do that's in my control that I can help make the situation better, or at least keep it the same that it is?
Right. Well, and preeclampsia is again this strange disease that if you can imagine a conveyor belt and you're on this conveyor belt that's going a certain speed, and it's headed toward severe preeclampsia requiring delivery, because the only real treatment, the only real cure for preeclampsia is delivering the baby. And even then, just immediate delivery, beaming the baby out 5 seconds from now, still you're at risk for the next couple of weeks, particularly the next 48 hours. But it's a conveyor belt to a severe form of preeclampsia. How fast the conveyor belt is going, we can't really control. It's all completely independent from one patient to the next. So you can't really control that. You're on the conveyor belt. You didn't intentionally get on there, but you're on there anyway. And so you're heading toward a severe complication, and we're not sure how fast. So watching your blood pressure very closely, probably taking yourself off of work, not because that's going to cure or fix the disease, but the fluctuations of your blood pressure from 1 minute to the next, that'll dampen the fluctuations. Stay out of the gym, for instance. That's why we used to prescribe bed rest across the board. Now, bed rest itself really doesn't fix preeclampsia or prevent it from going forward, but it will dampen it. So at least you won't see it. You're still on the conveyor belt. You're still going there. You can just prevent the spikes and that sort of thing. There's a unique part of preeclampsia where you're spilling a lot of protein. There's a syndrome within just the human body that's called orthostatic proteinuria. So the more you're up and around, the more protein you're going to have, and once you're lying around, you'll have less protein. But that's kind of a I don't know, red herring, I suppose, because it's not really real. This you can we'll take blood pressure medications. That'll fix it. Well, that doesn't fix the syndrome. You're still on the conveyor belt. You're just repressing or suppressing one of the symptoms.
This podcast is produced by Hand to Hold, a national nonprofit, but we're more than simply a podcast. Be sure to download our app, join one of our support groups, or find one-to-one support, enjoy counseling, find loss and bereavement support, participate in a peer-to-peer mentor program, or check out our news, articles, and family stories at handtohold.org. All of that is at no cost to you. Hand to Hold's mission is to provide personalized support before, during, and after a NICU stay to help ensure that all NICU families thrive. I think a lot of women who have preeclampsia feel like, if only I had known, or maybe they don't find out about their diagnosis till much later or even until after their baby's born, because the doctor thought it was this or thought it was that. I mean, how difficult is it to diagnose someone with preeclampsia? I guess I know you've talked about things that may or may not cause it, but how difficult as a doctor with the patients that you see, and as a maternal fetal medicine doctor, you probably see many more high-risk patients than the regular OB-GYN. That's sort of why you got into the specialty that you did, but how difficult do you find it as a doctor to accurately diagnose preeclampsia before it escalates and gets out of control?
Well, there's what's called the run-of-the-mill preeclampsia that follows a pathway, that little conveyor belt where you start having a little bit of swelling in your hands and your face, and you're about 32 weeks, and then you have a little bit of protein in your urine, and then you start seeing your doctor maybe every week rather than every other week, because he's worried, or he or she is worried about your blood pressure. And then you start maybe taking it at home, and you notice it's a little bit higher. It goes a little bit higher. Maybe if you were on pre-existing, had high blood pressure before the pregnancy, now you're getting superimposed preeclampsia. So your obstetrician, he or she raises your blood pressure medication, but your blood pressure keeps going higher, so it stair steps up. So as long as once the thought of high blood pressure crosses anyone's mind, once the thought of liver pain like a heart attack up under your ribs on your right side, feeling like it's called a liver attack because there's decreased blood flow to the liver. Nausea and vomiting in pregnancy, that's supposed to be a first trimester thing. If you start getting nausea and vomiting suddenly in your 32, 33 weeks, that's probably preeclampsia. Abdominal pain is probably preeclampsia. Swelling is probably preeclampsia. Decreased urine output is probably preeclampsia. Severe headaches, seizures, they think it's appendicitis or gallbladder disease. That's all preeclampsia. So what I do is I look at it from kind of a different end than most obstetricians. Is if something new is happening, I have to prove it to myself it's not preeclampsia, because those like HELLP syndrome, for instance, one of the severe forms of it, can look like gallbladder disease. If you have your gallbladder, a lot of gallstones, and you're in pain, and the pain causes your blood pressure to go up, well, is that gallbladder problems or is that preeclampsia? And it'll fool a lot of ER doctors too. I've had a couple of ER doctors that have been badly fooled by that. But by increased surveillance, going to your doctor more, doing home blood pressures once or twice a day, um, dipping your urine if you want to at home, you can certainly get the little urine dipsticks at CVS and look at protein in your urine. But things like that are just being a partner with your obstetrician, and sharing your concerns, sharing all of your symptoms, any new symptoms, particularly. And if it's mild, if it's like, they talk about the severe throbbing bifrontal headache that's up here. If you have a little irritating, tension headache back here, that's not preeclampsia. If it's some little irritating come and go thing or mild thing that goes away, it's not preeclampsia. Preeclampsia is one of those syndromes. The symptoms will get progressively worse from 1 hour to the next, from one day to the next. If you see something that's we call indolent, sort of this slow burn, but getting worse and worse, um, that's something to worry about. Something that, oh gosh, I had a headache and I took some Tylenol, it went away. That's not preeclampsia, but
Yeah.
it's being aware of what's different and communicating those different things with your doctor.
Well, I love that you brought that up, actually, that of all the relationships that we have with our doctors, certainly a woman's relationship with her OB-GYN is the most intimate and long-standing relationship that I
Oh,
think most people
absolutely.
will have with a doctor. And so if anybody's going to know you well, it's going to be your OB-GYN. And so I
Right.
hope this encourages
That's for sure.
in all the ways, but in all the good ways. I mean, I think that this is a good reminder to people who are listening that if you have a concern, that is the doctor that you should bring it up to. And if more testing needs to be done or referral to one of a doctor like you, like a MFM, then they should ask that question. Don't be afraid to advocate for yourself, or if you're noticing something that seems like not right. I think our intuition as women rarely disappoints us; it's usually
Right.
right, and so. I know that whenever we had our NICU baby, that the relationship between my OB-GYN and my maternal fetal medicine doctor was so good, and they really were just a great pair of doctors together. And I have been eternally grateful. Ended up saving our son's life. So I think don't be afraid to ask a question. I'm glad that you mentioned that.
No, for sure.
Um,
Well, and God has put me in this position, and praise God, because I have had the luxury and the uh, I just feel honored to be put in a position where women, essentially strangers, are coming to me, and I get to know my patients very well. We know, they know my kids' names and I know their kids' names, and we know each other on such an intimate time, and you can imagine that's kind of an artificial relationship. You wouldn't just walk into some
Mhm.
stranger's office and say, "Here, I'm going to get completely undressed. You tell you all my detailed stories of my past and what's going on. Have you examined me from head to toe, and then tell me what's going to happen in the future with your best guess and knowledge, and then be partners." But that does happen, and that's a blessing to me. I mean, that's where I get my joy, and that's why I still would do this if 25 years in the career. And I would still do. I get asked all the time, "Would you do this again? Medicine has changed so much. Would you do this again?" I say, "Absolutely." And I would do exactly the same career. Not very many people can say that.
I think you answered my next question. I was going to ask you. I mean,
Hmm.
unlike OB-GYNs, much of your job sometimes ends up being that you're delivering difficult news, that you don't know the outcome of whether it's going to be a positive or a really difficult outcome, but your daily job means that you deliver hard news to people every day. How, Dr. Berry, how do you continue to serve patients when sometimes you see that, man, this one's going to be a really difficult case? How do you have, I guess, the faith and the fortitude to go to the next patient and serve them well, knowing that, or not? I guess I should say, not knowing how it's going to end.
Well, and for the longest time, I had thought that I was, my knowledge and my, muddling through, 26th grade, so finish medical school, and we're, about halfway through, 12th, finish as finishing high school, you're not even halfway through 12th grade. It's like, well, I went through 26th grade. Now I think it's 27 years straight. But those things give you the kind of the book knowledge, but the book knowledge doesn't really help. My undergraduate degree is in psychology, and I have found, and this is probably only about 5 or 6 years ago, that I found my true my true gift, and this I do think is a divine gift and gift from God, that my gift is being a glorified grief counselor for women having the worst day of their life. And I still do that. I still do that every single day. Last week we had probably 4 babies that had horrific birth defects or problems that probably were not going to survive. And just to be there with that patient and talk with the patient and cry with your patient and pray with your patient, I still do that weekly, almost daily, depending on what problems come in. But we look at to ourselves for our strength, but strength has to come from somewhere else, because where is faith? Where is strength? Where does courage come from? It's really difficult to say or to answer. But once I realized my gift, literally a divine gift given to be a grief counselor in the midst of horrific news and getting patients from the worst day of their life, sometimes the best day of their life, future pregnancy, they come in, everything's beautiful and perfect, and we're hugging each other and crying because everything's awesome. But that's what I do. I bring home my wife was just talking to me a few days ago about this. I do bring home my sadness and my grief and my
Sure.
sadness for my patients, but it I kind of know where to put it, how to manage it, and how to kind of put it in a little box. But some people are just have a barrier up. Some healthcare providers and doctors have this barrier up, so they just like, no, that's not going to enter my soul. I'm going to keep that grief at bay.
Right.
I let it in, but I have filters and ways to to get it out, because I know that this is not the end. This is just the beginning for a bad chapter in someone's life. But how amazing is it to go from the worst day of your life to the best day of your life? I mean, that's if you've felt the lowest of lows
Hmm.
psychologically, once you feel the low, you can also feel an equal high. If you're in this tiny little narrow space of emotion, never felt a low bad emotion, you'll never feel a super high emotion. So, but I'm just honored to be part of a woman's adventure. I mean, it really is an adventure of a lifetime, and I'm being invited into to thousands of women's adventures.
I love that. That's beautifully said. I'd like to ask you. I could talk to you a lot longer, but I know that you
I'd,
you have
I'd
you
love
have
to talk to
patients
you.
you have
Uh,
patients that you need to serve. I I want to ask. I'm going to ask you two questions. So one is, what are some questions that a woman should ask her doctor if she has concerns that she has preeclampsia? What would be like the one question or two questions that you would say, ask your OB-GYN this so that you can get the help that you need?
so the first thing is, if you're in a high risk group, is if it's your first pregnancy, if you're an in vitro fertilization, especially with a donor egg, if you have previous diabetes, previous high blood pressure, previous lupus, uh, the kind of an autoimmune disease called lupus. If you've had any of those diseases, then be sure and talk to your doctor about possibly even starting in the first trimester, particularly, is being on a baby aspirin. So we were talking about inflammatory processes within the blood vessels. If you're on a baby aspirin a day, plus calcium, plus the DHA or omega-3 fatty acids in your prenatal vitamins, that it doesn't prevent preeclampsia, but it lessens the severity and delays the onset. It seems to not really work in multiple studies. It doesn't really work in low risk patients, but in high risk patients, first time mom, previous high blood pressure, diabetes, previous preeclampsia, for instance, donor egg IVF, twins and triplets and quads and quints, that sort of thing. Those patients are very high risk for high blood pressure in the third trimester. So early on, talk to your doctor about, are you a candidate for baby aspirin? And remember, he might not remember that baby aspirin and maybe a couple of Tums a day, so 1,500 milligrams of calcium, 81 milligrams of aspirin, and the DHA, the omega-3 fatty acids, can come from flaxseed oil or fish oil, or your local fish oil capsule. The one that come in your prenatal vitamins usually don't give you fish breath, so that's probably a better one. But that's up front, and then as you go through your pregnancy, if you're totally fine. Once you get to particularly beyond 28 weeks, you start having something going on that's unusual swelling, particularly in your hands and your face, unusual symptoms. One of the best uh, symptoms that I've seen, especially for patients that have pre-existing kind of low grade high blood pressure in the third trimester, and then a patient says, I just don't feel right. Something's wrong. If you get that air of turmoil or drama or trauma or oppressive symptom of just something's not right within your body, be sure and call your doctor. If he doesn't say it, go ahead and go to CVS and or your local Randall's or whoever has a blood pressure cuff and take your blood pressure. Or even better, buy a blood pressure cuff and bring it home with you. Take your blood pressure a couple of times a day. The cutoff that we have is 140 over 90. So if a top number is over 140 or the bottom number is over 90, not just once, but take it 2 or 3 times. If it's always up there, either one, 150 over 80, that's okay. That's one of, and 140 over or 130 over 95, that still applies to preeclampsia. But once you start having it, then to communicate that with your doctor.
So,
Really, any symptoms, any severe symptoms, severe headaches that don't go away, severe abdominal pain that doesn't go away,
yeah.
nausea, vomiting that doesn't go away, the swelling in your hands and your face, or high blood pressure, any of those things, then be sure to let your doctor know. And if they don't respond, then call my office. I'll see you the same day.
I love that. I think that education is probably the best thing that we can do as women who are carrying babies is learning what's out there and being aware of your own body and communicating that with your doctor. I guess if there's a woman listening to this, Dr. Barry, who's just gotten a preeclampsia diagnosis, I know we've given her a lot of education, but what would be your wisdom that you would want to impart to her with that diagnosis?
Well, number one is I tell my kids, I've got 4 daughters and now 3 stepsons, so I've got 7 kids. So like you, I'm on the higher end of
You are.
parenting. And rule number one in our household was don't freak out. So don't freak out is number one. So, okay, now calmly say, okay, now what are we going to do? I think the blood pressure twice a day is a good idea once you have the diagnosis. If you talk to your doctor, see if he or she wants you to dip your urine for protein at home. Certainly see your doctor at least once a week, sometimes twice a week, and report any sort of symptoms. As far as intervention to actually cause you to go further or cause you to have a longer gestation before it gets severe, there's really nothing you can do, but take it easy. Don't go to the gym. Don't go for a 2-mile walk with your dogs, and just kind of hang around the house. Put on your bunny slippers and your robe all day, and kind of be the princess for the day. Let somebody else take care of you. If you have a stressful job, unfortunately, you're going to have to tell them, you're going to have to take some time off. If you can work from home, that's totally fine, but it's just kind of taking out, we don't want you on bed rest. Then you can't even come to the doctor's office because you're on bed rest. You can't leave, right? But yeah, just and keep a good watch. Even keep a little journal. What are you feeling? What are your blood pressures? What's going on with your swelling? And bring your journal to your doctor's appointment.
It's good
But yeah, just
advice.
be aware. It's not it's not the little things. It's the oh my gosh thing. As one patient came in to see us. Um, I see one of my colleagues an OB clinic here in Austin, and she had super high blood pressure, 180 over 102 or something like that, and told to go directly to the hospital. And they were like, well, they didn't have a ride, and they just went ahead and went home. And the patient was feeling bad. She was only 18 years old, and so her mom went ahead and, she's living with her mom. Mom went ahead and said, okay, what's all right? You're tired. Let's not go to the hospital. Let's just go to bed. Let's go to sleep. And then her mom found her. She had fallen out of the bed twice overnight, apparently having seizures. And her mom's like, "Oh, you're just tired." To put her back into bed and waited till the next morning. So by the time she got to our hospital up at Seton, um, she was extremely sick, having multiple seizures one after another, and we had to rush her into lots of medications, lots of IVs, and we actually had to bring her into the operating room and C-section with only one small IV present, which they could do anesthesia through, but they couldn't like give blood products and that sort of thing. So we had to put her to sleep with her tiny little IV, uh, secure her airway, stop her seizures, deliver the baby. While we're doing that, we're starting a central line up in under her collarbone. So we're doing all that right at the same time, and we had to figure out the best way to do this to make sure a healthy baby, healthy mom. And it turns out she was in the ICU for 24 hours, and she's up and around totally fine. 24 hours later. And so, young 18-year-olds and young pregnant women are usually very resilient. So they recover exceptionally well. So even if you get preeclampsia, it goes away. So you're not gonna have any residual things from it. Just don't let it get to that point. Don't ignore it.
Right. let that be our lesson to
Yeah,
listen to your
don't
body,
yeah,
listen
listen
to
to
your
your body
body and talk to your doctor.
and don't ignore it. And it sounds kind of trite and kind of silly, but it's really true, and that's the communication at the end is the most important.
Well, Dr. Barry, thank you for giving us a little bit of a background, a lot of education, and really a lot of reassurance and encouragement that it matters who your doctor is, and it matters what questions that you can ask them, but it also matters that you learn to be an advocate for your body and for your baby. So thank you.
Absolutely.
Ooh, deep breath. I mean, I knew that I was going to love that visit with him. I knew that I was going to gain some great information for y'all. But boy, howdy, do you learn what what it matters, what kind of maternal fetal medicine doctor you have. It matters. They have such an ability to have compassion. So in today's 2-minute take, there is so much that I want to recap, but I'm going to focus on really two things. One, and I'm so glad it came up so organically in our conversation, but I'm so glad that he said this, that you did not cause what is happening in your pregnancy. So many of us, me included, sat in my maternal fetal medicine's doctor's office and felt like surely there was something that I did that caused this terrible, awful thing to happen. Surely there was something that I could have done to have prevented it. And in his interview, he reminded us that in the most minuscule of cases, two in his 27-year career, has the mom been the one that caused what happened to her baby. So many of you are sitting there, and I hopefully alleviated your guilt in saying that his job is to get you to the best possible outcome, and you are doing the best job that you can. And I don't know about y'all, but I needed that assurance. Even all these years later, it was so comforting to hear him say that. And then the second part, probably equally important, is talk to your doctor. We talked about this when I interviewed Dr. Summers earlier this year about navigating a high risk pregnancy. The communication that you have with your OB-GYN and then the subsequent communication that can happen afterwards. So that when that OB-GYN visits with your maternal fetal medicine doctor and how you play a role in that very important relationship, it matters. Ask the questions, be the advocate. I love that he's saying what she said all those weeks ago, that your advocacy and your questions are important to getting the best care that you can get for you and your baby. So next week, we will talk even more about preeclampsia. I cannot wait to dive into that. So until then, I'll see y'all next week. Thanks, y'all, for listening to NICU Babies Parent Support. Every parent and every experience is welcome here. If you are a NICU parent and you're finding yourself in need of support, please download our app. You can find it in the Apple Store or on Google Play, Hand to Hold. And if you love today's episode, you can share it, you can subscribe, and you can most certainly review it. We would love, love, love your reviews. It's how we reach more NICU parents. Thanks, and I'll see y'all next time.